I'm Peter Schmid. I'm a medical oncologist and work at Barts Hospital in London. It's my pleasure to talk to you today about the really massive advances we have made in the management of triple-negative breast cancer. The way we are treating triple-negative breast cancer today is dramatically different to where we were 5 or 10 years ago. And this is just the beginning of hopefully an evolution that will continue to improve outcomes of patients with this difficult to treat disease subtype. Now, if you look at where we were about 10 years ago, in primary breast cancer, this was prior to the introduction of immunotherapy. So a substantial proportion of patients had primary surgery followed by adjuvant chemo, but increasingly patients were treated with neoadjuvant chemotherapy. The role of platinum was not clearly defined, and patients who had residual disease were just starting to be considered for postoperative capecitabine treatment. We know with metastatic triple-negative breast cancer, the recurrence happens unfortunately relatively early, on average after around 18 to 24 months. And if you look back to the way we treated back then, only about 10 years ago, first-line treatment was generally taxanes or platinum combinations, and on average, patients would stay on this treatment for about 3 months. Only 3 out of 4 patients would be well enough and would be able to receive second-line treatment, which typically would have been capecitabine or eribulin, and stayed on it on average for about 9 weeks. Only half of the patients would be able to have third-line or subsequent-line treatments. And again, typical treatments could have been eribulin or already best supportive care. And as a result, only in 2018, our median survival was around 12 to 15 months for patients with metastatic triple-negative breast cancer. Now, one of the first big steps to change that was the introduction of immunotherapy. And if we look at the first single-agent immunotherapy trials, the data came out around 2017, 2018. There are 3 things we learned from those studies. The first thing is immunotherapy worked. We saw objective responses in patients with metastatic triple-negative breast cancer, but what was very evident is that the treatment worked better the earlier patients were considered for it. So if you look at the response rates here with atezolizumab or pembrolizumab in those non-randomized early studies, they're around 25% roughly for patients in a first-line setting, but we're only around 5% in patients with more heavy pretreatment. The second thing we learned is if patients do respond, it can sometimes be transformative. And in one of our very first studies, the duration of response with immunotherapy single agent was 21 months. And that led to, if you look on the right side of that slide, to a clear, better outcome for those patients. In green, we can see those patients who achieved a complete or partial response with immunotherapy, and their overall survival was markedly better in this non-randomized trial compared to patients in blue who had stable disease or in red who had progressive disease. So clearly immunotherapy, even in the early studies, showed a promising result. And so our first step was to try to establish immunotherapy as single agent therapy. Now when we designed Keynote 119, randomized trial, pembrolizumab versus treatment of physician's choice chemotherapy, it was designed in second and third line setting. But we designed this trial before we had all the results from the previous studies available. And with the knowledge we have now, it probably wasn't the wisest decision to design this trial in pre-treated patients. And so it was not a surprise that a trial was negative in terms of its primary endpoint, in terms of overall survival. But it's interesting to look at those data in a bit more detail because we can learn a lot. If you look at the left side of the slide, you can see the different patient populations. ITT, all patients, and CPS is referring to PD-L1 staining in the tumor, means a little bit of PD-L1 staining with CPS1, intermediate or relatively high CPS is 10, very high expression is CPS 20. And the higher the PD-L1 expression this tumor is, the more immunogenic the tumors are, the higher the rate of TILs is, but also the smaller the patient population. Now, if you look at the trial outcome data, specifically for those exploratory subgroups, you can see the response rate goes up with the increasing PD-L1 score. And if you look at patients with a CPS of 10, even in a second, third line setting, we have a response rate of nearly 18%, CPS 20, 26%. And if you look at overall survival relative to standard chemotherapy, you can see there's a very clear signal for patients with higher PD-L1 expression that even single-agent immune therapy may be of value. So the question that is for me still open, but of course the field has moved on, is there possibly a role for patients with very immunogenic tumors with a high CPS score for single-agent immune therapy? But clearly that is not how the registrational studies then happened. And then further development was really focusing on patients receiving combination therapy in combination with chemotherapy. If you look at the data combination trials in first-line setting, two big phase 3 trials, very similar design, IMpassion130 on the left with atezolizumab, KEYNOTE-345 on the right with pembrolizumab, both in first-line setting. Slightly different chemotherapy backbones. IMpassion130 utilized nab-paclitaxel because at that time we were concerned around the possible use of steroids in the context of immune therapy. Pembrolizumab, the study was a year later, utilized more chemotherapy options with paclitaxel, nab-paclitaxel, and gemcitabine carboplatin. The data ultimately are remarkably consistent. If you look at progression-free survival in both trials, you can see a hazard ratio of around 0.62, 0.65, clear improvement in progression-free survival, but only in patients with PD-L1 positive tumors, whereas in patients with PD-L1 negative tumors, and that was defined as either an SP142 assay of less than 1% or 2 to C3 assay with a CPS of less than 10. In those patients, there was no benefit from immune therapy. Now, the benefit in progression-free survival also seems to clearly translate into a benefit in overall survival. And again, if you look at the two studies, relatively consistent results, hazard ratio 0.67, although in IMpassion130, that is only an exploratory analysis based on the hierarchical trial design. And in KEYNOTE-355, hazard ratio of 0.73, again, pre-planned and co-primary endpoint. What is really important to point out is if you look at the absolute overall survival, 23 months, 25 months, the first time we crossed the magical 2-year threshold for patients with metastatic triple-negative breast cancer. And that made immune therapy the standard of care in a first-line setting. That brings us to our first case of a patient with metastatic triple-negative breast cancer, 42-year-old lady who did not have a BRCA or PALB2 mutation. She received initially for a T3N1 disease, neoadjuvant chemotherapy with AC followed by paclitaxel carboplatin, and a reasonable clinical response, but substantial residual disease. And at that time, that was prior to the date of capecitabine, did not receive adjuvant therapy. She had metastatic recurrence, unfortunately, within 2 years from the end of her therapy, involving liver, bones, and lymph nodes. She had a PD-L1 positive tumor, but also had low HER2 expression. And as per data we offered her, and she received first-line chemotherapy, nab-paclitaxel and pembrolizumab. She had good partial response, but developed after about 6 months grade 1 to 2 peripheral neuropathy, and we stopped chemotherapy but continued on pembrolizumab. Unfortunately, after nearly 2 years of therapy, so very good long response, but unfortunately the patient developed expectedly further disease progression, and this time involving liver, but also new peritoneal mets. And the question really is, what do we do in a patient now in such a situation? Do we give further chemotherapy? Do we give chemotherapy bevacizumab, which is obviously not licensed in the US, but is still commonly used in other parts of the world? Or is this a time to switch to one of the other conjugates, sacituzumab govitecan or TDXT? In this patient, we switched to sacituzumab govitecan. She initially did very well, but reported grade 2 fatigue. She struggled with exhaustion and some of the activity of daily living. What would we do in such a situation? Would you just carry on? Would you hold the treatment at dose reduction? One of the things we see quite often with ADCs, that is, patients experience early fatigue, but that can improve them with subsequent cycles. So it is worthwhile trying another cycle. But if the fatigue at that level persists, then we need to consider a dose reduction, as we did for this patient. We carried on with the treatment. She developed later grade 3 diarrhea with 7 to 9 bowel motions per day. Again, the question to you is, what would you do in this situation? Continue with the treatment, or hold the treatment until the diarrhea has resolved, give loperamide, or discontinue the treatment overall. The right thing from our perspective to do is hold the treatment until diarrhea has come back to grade 1, so frequency for up to 3 times a day. And of course, loperamide, which we increasingly also give as prophylactic therapy. But the diarrhea in this patient resolved within 4 days. And the key question is does this mean we should reduce the dose? Yes and no. Well, based on the current guidelines, if it's relatively quick resolution of diarrhea, patients can actually continue on the current dose, which we did for this patient, and she did very well and managed to stay on this treatment for quite a bit longer. Now, what happened with the patient is she had initially a good partial response, but then after around 8 months, we found that she had a solitary brain metastasis. The rest of the disease was still in a partial response. What would you do with this patient? Would you continue? Would you give cyberknife therapy, continue with sacituzumab govitecan? Would you switch to chemotherapy or a different ADC? Our strategy was to give cyberknife therapy to the oligoprogressing brain metastasis and carry on with systemic therapy. And we managed to keep the patient on this treatment for another 6 or 7 months. That leads us over to antibody-drug conjugates, which I already mentioned. You're all well aware of the concept of antibody-drug conjugates. These are antibodies that usually target a tumor-specific antigen, but also have then a very potent chemotherapy drug, they call the payload, glued to the end of the antibody. And as you can see in orange, there's this molecule called the linker, which using the word glue is probably not right, because it's very sophisticated biology behind there that has the principle of keeping the chemotherapy stuck to the antibody until it reaches the cancer cell, but then releasing the chemotherapy drug in the cancer environment and not in the rest of the body. And if you look at the old-fashioned concept or old-fashioned understanding how ADCs work, we used to think they bind to the cell surface, they have to be internalized, the antibody gets broken down, and then the chemotherapy drug gets released inside the cell. We have learned now that with the third generation of antibody-drug conjugates, we have additional mechanisms of actions, and I think they're critically important for the increased activity. One is that the chemotherapy drug can diffuse out of the cancer cell again, and therefore also target immediately surrounding other cancer cells. We have also learned that some of the ADCs can release the payload, the chemotherapy drug, upon binding without internalizing the actual ADCs. Both of this means we are not just able to tackle the target positive cells, which are here on this little cartoon, the pink cells, but we can also, with this bystander effect, tackle the target negative cells. And this is one of the main drivers why these third generation ADCs are so much more effective. Just to look at this in terms of target expression, second generation ADCs, these were drugs such as TDM1, required a relatively homogeneous high target expression to be active. But with the third generation, we can have relatively low expression and heterogeneous expression, which we often see in metastatic disease, to still have some activity. And even with ultra low expression, as little as 2% of tumor cells, if they are positive and in the right distribution, the treatment may still be highly active. What we are learning is it's probably not just the absolute expression of the tumor antigen, of the target antigen, but it's also the distribution. If you have 2 clusters of positive cells very far away from each other, it may be that the ADC doesn't work as well as if positive and negative cells are almost sort of interwoven and mixed up. But these are things we're learning as we go forward. There's a plethora of targets we are exploring at the moment. Again, this is reflective of the change in the concept and biology of ADCs. We used to do, and if you go back 20 years ago, we developed ADCs that would only target the oncogenic driver, HER2 and HER2 high patients. But we've learned now we can actually target we use any tumor-specific agent as a target for an ADC, as long as the antigen is expressed on cancer cells. But it can also possibly even be expressed on the vasculature, on the stroma. So this has widened our abilities to select for new targets in the tumor And we don't always have to look just what drives the cancer in its biology, but also what is differentially expressed on cancer cells. Here's just a list of some of the targets from Nectin-4 to B7H4. TROP2 we will talk about in detail. We'll get back to HER2, HER3, but this is obviously a very incomplete list considering the different agents that are coming through. And here just some on a very superficial level in the early studies, some of the data we have seen with different ADCs, different targets, seeing impressive early response data. Now, the target and the ADCs to the target that have probably had the most impact on triple-negative breast cancer to date are ADCs targeting TROP2. TROP2, for those of you who don't know it, it's a transmembrane glycoprotein. It's overexpressed in many epithelial cells, including breast cancer. It's not really expressed on normal tissue. We can of course talk about whether that has a clinical relevance for breast cancer, but ultimately it's not an important protein for breast cancer, but it is a fantastic anchor for ADC treatment in breast cancer. There are 2 ADCs that are now approved in breast cancer, not necessarily in triple-negative breast cancer, that target TROP2. On the left side, you see sacituzumab govitecan, humanized antibody, SN38 payload, which is a derivative of irinotecan, and then again, linker biology, hydrolyzable, high drug antibody ratio, 7.6 to 1, and it does not need to be internalized to release the payload in the tumor environment, which is down to the substantial bystander effect. On the right, you see datopotamab or dato DXd, which again has a humanized TROP2 antibody. This time, deruxtecan is a payload with a stable linker, a biology tumor selective, and an optimized drug antibody ratio of 4, and also, as all third generation ADCs have, has a bystander effect. If you look at the first data we saw for sacituzumab govitecan, this was in one of the very early phase 1 trials, and there was something very unusual happening. For those of you who treat triple-negative breast cancer frequently, you can see we see activity in first line, we see some activity in second line with chemotherapy, but when it comes to third line setting, chemotherapy does not work very well anymore. So here we saw in this phase 1 study an objective response rate of 33%, clinical benefit 45%, duration of response 7.7 months, PFS 5.5 months. Was a mind-blowing early activity. And the question was really, is this down to patient selection, and how long is this maintained? And I find the figure on the left really interesting, really helpful, because that addressed for me the question of patient selection. So you see in red, the duration, each line is the duration and how long a patient is on the immediate prior therapy. And then in blue, you can see how long patients were on sacituzumab govitecan. And so if you, for example, go down from the top to the third patient from the top, she was on the chemotherapy for only 2 months before she was switched to sacituzumab govitecan and stayed on that treatment for more than 2 years. So clearly, these drugs have high activity, and it's not just down to patient selection. So when sacituzumab govitecan moved into phase 3 trial, ASCENT, in patients with at least 2 prior lines of therapy and compared to treatment of physician's choice, which included eribulin, capecitabine, vinorelbine, or gemcitabine, our hopes were very high that this would meet the primary endpoint, and the trial did in a very impressive way. If you look at progression-free survival, we have a hazard ratio of 0.41. If you look at the subgroup of patients with bone metastasis, the hazard ratio is still 0.43. So clear, almost tripling in progression-free survival with sacituzumab govitecan compared to standard chemotherapy. If you look at overall survival, nearly doubling, and these are patients who are heavily pre-treated, but overall survival went up from just over 6 to nearly 12 months, really important. But let me focus on a secondary endpoint. You may say that's not that important, a response. But from a clinical point of view, response is really important. If you have a patient in front of you who has symptomatic disease caused, for example, shortness of breath, if we just induce stable disease, the symptoms will persist. So making the tumor smaller resets the clot, improves the quality of life, and allows patients to have other subsequent treatments. If you look at the response rate here, 7 times higher with sacituzumab govitecan, 35% compared to 5% That is how shockingly low the activity of chemotherapy is in those pre-treated patients. If you look at the safety profile, what was very evident, third-generation ADCs are more like single-agent chemotherapy. And yes, we do see significant toxicity with single-agent chemotherapy as well as the sacituzumab govitecan, for example, a gastrointestinal the gastrointestinal symptoms, but also neutropenia. But with experience in the team, we increasingly learn how to manage those toxicities. In our clinical practice, these patients tolerate the treatment now much, much better. Let's use this opportunity to go to a second case. This is a 53-year-old patient, again, without a BRCA1, 2, or PALB2 mutation. She presented with de novo metastatic TNBC, liver mets, PD-L1 negative, but HER2 low expression. She received first-line single-agent chemotherapy back in 2019 with paclitaxel, had a reasonable response, but we had to stop the treatment because of grade 2 peripheral neuropathy. And almost expectedly, unfortunately, within 3 months, her disease progressed. She received second-line gemcitabine carboplatin, worked for a short while, for about 7 months, and then had multiple liver metastases. So question, what would you do? Would you give sacituzumab, govitecan, TDXD, chemotherapy, or chemotherapy and bevacizumab? This patient very successfully was treated with sacituzumab govitecan, stayed on treatment for just around 10 months, but then developed new progressive disease in liver and lung. And here really is the question, can we now, patients has low HER2 expression, can we consider a second ADC? Can we possibly consider this patient for trastuzumab deruxtecan, or would you switch to eribulin, or possibly even give Data-DXd, another ADC that targets the same TROP2 antibody? We decided to give this patient TDXD, and actually she had a reasonable response of around 7 months, which we were very pleased in this situation. So if you look at other ADCs, in addition to sacituzumab govitecan, I already mentioned Dato-DXd. We haven't got phase 3 data yet in triple-negative breast cancer, but you are probably aware of the phase 3 data of Dato-DXd in ER-positive breast cancer. In triple-negative breast cancer, we have data from this non-randomized trial, and I think that it's really interesting to look at this in a little bit more detail. High response rates, again in the 50% range for sacituzumab govitecan or DXd-naive patients. But if you look at the color coding, there are some patients that are marked in blue. These had no prior ADC treatment. Patients marked in this orange color had prior sacituzumab govitecan, so a different ADC targeting the same TROP2 target. And patients in yellow had prior treatment with DXd with another ADC. And you can see that patients can respond to a subsequent ADC, whether they had prior same payload or same target. And it tells a little bit about resistance to ADCs, which we'll get back to in a minute, which can be driven by target or payload. The other point to mention is the safety profile is very, very different between different ADCs. And here, for example, we see more stomatitis, but less diarrhea compared to sacituzumab govitecan. So it is important to recognize each of those drugs as a unique drug with its own safety profile. The new or the third possible kit on the block is a new drug called sacituzumab TMT, which again has been trialed in a phase 3 trial, predominantly in China, similar to the ASCENT trial, at least 2 prior lines of treatment versus treatment of physician's choice. And you can see similar results with a substantial and really meaningful improvement in progression-free survival, overall survival, and again, similarly, much higher response rates with ADC compared to the chemotherapy. And we will see much more of that drug in some of the ongoing trials. What about HER2 as a target in triple-negative breast cancer? You're aware of the initial classification of HER2 positive being driven by the benefit of trastuzumab, which was only seen in patients with IHC 3+, or patients with ISH amplification if they were IHC 2+. And everyone else was called HER2 negative, even if patients had low expression, because there was no benefit from an antibody treatment. But we have seen very clearly from the early studies that even patients with low expression may benefit from antibody-drug conjugates such as sacituzumab govitecan. And you can see that the expression is probably 2 out of 3 patients in ER-positive breast cancer and at least 1 out of 3 in triple-negative breast cancer. So this is a valid strategy in triple-negative breast cancer. And if you look at the phase 3 data, a combined trial including patients with hormone receptor positive and triple-negative breast cancer, where the triple-negative cohort was relatively small, in pre-treated patient, second or third line T-DXd versus standard chemotherapy in patients with low HER2 expression, you can see a substantial benefit in progression-free survival, regardless of the tumor type, here for triple negative. Same for overall survival, very similar signal, regardless whether it's ER positive or triple negative breast cancer. And again, for me, and again, I sound very old-fashioned when I come back to this, response rates incredibly high, of nearly 50% with triple negative breast cancer, which is important because this drives patients' quality of life benefit. Now, I already mentioned resistance as a key theme to talk about, because as exciting as these ADCs are, as effective as they are, unfortunately, over time, all patients will develop resistance. And there was a really interesting study by the Boston group published a few years ago, patients on sacituzumab govitecan, serial biopsies, but also that analysis post-mortem, looking at the different metastatic lesions and checking out what drove resistance. And in a nutshell, we see even in the very same patient, the two key mechanisms. One is here alter TROP2 binding, which is resistance to the target. But we also see failed SN38 topo1 binding, which is payload resistance. And those are the two main resistance, and they are often subclonal, as you can see on this tree here. What does it mean clinically? It means if we have subclonal resistance, we sometimes have something called oligoprogression. Oligoprogression means just one part of the disease grows, and we can possibly treat this locally and keep the ADC in there. But it also teaches us something about rational sequences, combinations, and we'll talk about the combination with immunotherapy in a minute. Now, how do we do sequencing at the moment in outside clinical trials? We have limited data. We have some real-world experience data where ADC1 was used after ADC2 and vice versa. And what is really, for me, evident is the activity with ADC1 is almost highest. So you see here on the left side, the first ADC, how long patients were on there. And then next to it, you see the second ADC. And in red is sacituzumab govitecan, in blue is T-DXd. And then there was another group of patients where it was the other way around, who started on T-DXd and had sacituzumab govitecan afterwards. And as both drugs use a payload from the same class, it is a lot of overlap in terms of efficacy. And I would say the activity probably reduces to around a third if you use the same payload. Similar data, different study, ADC1, ADC2, you can see it can still work, but the activity is markedly lower. What's coming through, there's a number of agents coming through, and I just wanted to select two of them for you today, but that's of course just a biased selection. There are many other ADCs that are being developed. Interesting data from last ASCO with what we call EV or enfortumab vedotin. Why did I choose this? Well, because it has a non-cross-resistant payload. This is a microtubule agent payload rather than a topo1 isomerase inhibitor. And you can see there is activity here. The activity there, not earth-shattering, but we clearly see a PFS of around 3.5 months post-TROP1 ADC. A topo1 ADC, and I think that's really important because the chemotherapy in this setting had a PFS of about 1.6 months. So we can see, even with this, in these very early studies, we see a promising activity signal that should be further pursued. And another drug that came, where the data were presented at ESMO Breast earlier this year, an anti-B7H4 ADC, and Emi-Le, as it's called in its short form, again, is a B7H4-directed ADC, has an auristatin microtubule inhibitor payload, so non-cross resistance to topoisomerase 1 inhibitor with a drug antibody ratio of 6. And the study population here is interesting. The vast majority of patients had a prior topo-1 ADC, 93%, and 25% had both. B7H4 high expression was seen in probably roughly 40%, low in about 60%. And you can see, obviously, small number studies, but the response rate around 23%. And if you look at the patients with high B7H4, it looks like a promising PFS and overall survival in this subgroup at a relatively acceptable toxicity profile. And these are just two examples of drugs that are coming through where we will hopefully learn much more in the months and years to come. So where are we with our management of TNBC right now? This is early breast cancer, what you see in front of you. We have a new standard of care in stage 2 and stage 3 triple-negative breast cancers, preoperative neoadjuvant chemotherapy and immunotherapy. In stage 1, increasingly also neoadjuvant therapy and decreasingly adjuvant treatment. And patients with a path-CR, at the moment we continue with immunotherapy. In patients with residual disease, we have the options of capecitabine with or without immunotherapy, olaparib, again, with or without immunotherapy, and other studies with ADCs ongoing. If you look at metastatic first-line setting, and this is what we're here to talk about today, at this point in time, the standard of care in PD-L1 positive patients, chemotherapy and immunotherapy. In PD-L1 negative patients, it's usually taxane or platinum patients, and BRCA mutant patients, obviously PARP inhibitors. In the second line, you can see how colorful this has become. Sacituzumab govitecan is there very firmly as an ADC, and then in subsequent line, again, for patients who haven't had sacituzumab govitecan, that would feature there, or trastuzumab deruxtecan. But of course, we are working on changing that, and just one of the data from one of our trial patients, 63-year-old old lady who presented about 10 years ago with primary breast cancer, at that time actually was ER positive, had standard treatment, AC taxane and trastuzumab for her HER2 positivity, had metastatic disease recurrence with in about 6 years later with lymph node and bone metastasis, and was found to be HER2 negative at that time, on amplification of PD-L1 negative. So what would you do? And we happened to, obviously the standard of care was at that time chemotherapy, or in some parts of the world, chemotherapy and bevacizumab. We happened to have ADC trials ongoing. So we offered this lady an ADC trial, and she received Dato-DXd, TROP2 ADC, and durvalumab, and had a fantastic, very long-lasting response, which is ongoing, of more than 3 years to date. So that brings us to the combination of ADCs and immunotherapy. And there is, and I'm of course slightly biased, but there is something exciting going on when we combine ADCs with immunotherapy. The ADCs have the potential to really change the tumor microenvironment. And we did 2 early studies, one on the left with Dato-DXd plus durvalumab. This was in first-line metastatic triple-negative breast cancer, and nearly 90% of those patients were PD-L1 negative. That's important because we know, I showed you earlier, immunotherapy doesn't really work in PD-L1 negative tumors when combined with chemotherapy. And if you look at KEYNOTE-345 and PASSION-130, the response rate with chemo in PD-L1 negative tumors is around 40 to 45%. The PFS is around 6-7 months in that setting. Now, what we saw here, combining an ADC, Dato-DXd, and durvalumab in this setting, we saw a response rate of 79%. We saw a PFS of 13.8 months. We saw a median duration of response of 15.5 months. And those are data that were unheard of in triple-negative breast cancer, especially in PD-L1 negative patients. And then we confirmed the data with a different ADC, sacituzumab govitecan, and a different checkpoint inhibitor, atezolizumab, in first-line TNBC, PD-L1 positive this time, response rate nearly 77%, but again, PFS 12 months, duration response 40 months. So something exciting is happening here. And we can see, we're excited about the data, and we're eagerly awaiting them when they're presented at ASCO this year, ASCENT-04, which is the first phase 3 trial taking this concept forward. First line, metastatic TNBC, PD-L1 positive tumors, which is a CPS of 10 or higher. And patients, standard of care is chemotherapy and pembrolizumab, but patients were randomized to this or to sacubitril and pembrolizumab. And if you look at the progression-free survival hazard ratio 0.67, it's about from 7.8 to 11.2, clearly significant better progression-free survival. But I'm almost more excited about the duration of response. The duration of response from 9 months to 16 months. And again, that's completely in keeping with the other data sets I shared with you before. Response rates high around 60%. And this obviously has over time the potential to become one of the new standards, although it's important for us to wait for the overall survival data. What you can see on the right side is treatment-associated side effects. And what I find interesting is if you look at the side effects leading to discontinuation of therapy, 12% with SG and 31% with chemotherapy. Dose reductions, relatively similar. Dose reductions, relatively similar, a little bit higher in chemotherapy than the SG. So that already suggests that the combination is well tolerated and there's no emerging new safety signal. If you look at the side effects in detail, it looks very similar to what I shared with you early on from ASCENT for chemotherapy where there's SG. The addition of the immune checkpoint inhibitor does not alter the side effect profile. And one of the things, again, maybe we could discuss it a little bit later as well, is my experiences with increasing experience of the treatment teams. These side effect profiles improve dramatically. So, for example, we see hardly ever diarrhea these days with SG. We see hardly ever nausea these days with T-DXd because we are managing patients much, much better. And I think the trial data in real life will be ultimately better tolerated. If you look at some of the adverse events of special interest, again, there's no really new symptom. Pneumonitis is obviously the one side effect. Everyone is always a little bit anxious when we look at ADCs and immune therapy. But as you can see here, the pneumonitis risk seems to be exactly the same in chemotherapy or SG-treated patients and down to the immune checkpoint inhibitor. Now, where are we? Where are we heading? You've already seen this slide of breast cancer. You have seen where we are at the moment in management in metastatic triple-negative breast cancer. What trials are ongoing? One of the big questions for us is, what is the role of immune therapy in patients who may have had immune therapy for early triple-negative breast cancer? We haven't got an answer to that. But if I have patients who had immune therapy in early disease and who have metastatic recurrence and who are PD-L1 positive, I would re-challenge them with the immune checkpoint inhibitor because I think there's very little to lose. But also, we have now with the ADC combinations, possibly drugs that can change the tumor biology in a way that we can make immune therapy work. We need to look at ADCs in combination, in particular in the immune therapy combinations. And we have already seen positive phase 3 data in PD-L1 positive patients, but we can discuss in a minute whether it may be worth considering this in PD-L1 negative patients as well. And we have all the different ADCs coming through and need to work out how best to sequence them. What studies are ongoing? We looked at in PD-L1 negative patients. There's ASCENT-03, which is sacituzumab govitecan versus standard chemotherapy, and TROPION-Breast02, which is Dato-DXd versus standard of care chemotherapy. And many of you may have already seen the press release that ASCENT-03 is positive. The data have not been presented, but are expected at one of the upcoming meetings. And obviously, we can't share them yet, but it is very encouraging to see that this trial is positive. The PD-L1 positive trials, we shared ASCENT-04. There's a similar trial, TROPION-Breast05, ongoing with Dato-DXd and durvalumab versus standard of care chemo and pembrolizumab. There's a small trial we are running at the moment, which I think is interesting from a biological point of view, an academic study looking at patients with PD-L1 negative tumors and considering Dato-DXd alone or with an immune checkpoint inhibitor to explore this hypothesis that we can possibly render tumors that are normally not suitable for immune therapy effectively treated with immune therapy. So the treatment algorithm for triple-negative breast cancer becomes more colorful. We have many more options. We cure more patients in early disease with chemotherapy and immunotherapy. We will incorporate ADCs. But of course, there's also a lot of questions open, and I look forward to discussing them with you going forward. Thank you very much.